Sonia madam, what is your experience? How to which size of myomas have you used it?
I have not used it at this. I have not used it in any of these big fibroids at all.
Yeah, even me. Up to 5 centimeters, maybe I am happy using it. And probably with the 10 centimeters, I don't know how far the size of the myoma will come down. I think again,
even I have not used it in more than 5 centimeters. Because if it's a larger is the fibroid, the size reduction will take time, and how long you can give the treatment.
So maybe such patients, they should be shifted to surgical management.
Yes, yes.
So the limitation we can say up to 5, maximum 6 centimeters. So again, this Ulipristol versus GnRH analogs we have discussed enough. And again, there are a lot of drug interactions with herbal products and barbiturates, carbamazepine, greaseprevir, phenytoin, rifampicin, and etc. So because it is being stabilized by CYP3A4 inhibitor, so that we have to be very careful. So I think now this is how they give the Ulipristol course. We have discussed it. Start on day 1 of the menstrual cycle. And now the current thing is you can start on any day of the menstrual cycle. Okay, then give for 5 milligram, continue for. So there are certain prerequisites. Prior to starting Ulipristol, how do you counsel the patient and what are the basic investigations would you like to do?
So that
I think we have to do liver function. Yeah, Dr. Sonia, go on.
No, it's I think we have already discussed it when we were talking about contraindications, no?
Yes,
yes. These are the things that we have to be careful about. We have to rule out, like Asha said, malignancy, liver disease and all that. So we have to counsel the patient very carefully in the beginning also about all these things, because anytime during the course of this medication, if the patient comes with liver toxicity, we have to stop the drug, no? So therefore, that has to be told to the patient that, okay, we are giving it to you, but we may have to stop it in between. That counseling has to be done. And of course, along with that, we have to keep on guarding against any of these things coming up. That is important all through the thing.
Talking about heavy bleeding and Ulipristal, I think the way it can control bleeding rapidly is very impressive.
Yes.
Because once we had this lady with three submucous fibroids,
amazing,
young girl, married 1.5 years. She came with menorrhagia, heavy bleeding and hemoglobin of 6 grams.
Yeah.
So we had put her on 1 dose of GnRH, but then we know that GnRH takes time to act. So I started on Ulipristal and she had 3 myomas, 3 centimeter, 3.5 and 1.5. At the end of 3 months, this tiny one disappeared. The 1.5 centimeter had absorbed. We did a hysteroscopy and removed 1 myoma first, excision. We didn't want to have the 2 fibroids removed and get because very rarely I have seen 3 submucous fibroid. So we removed 1 fibroid. Then after 2 months, we did the second myoma resection by hysteroscopy. And 2 months after that, she has conceived naturally without any other therapy. She was a young girl, young slim girl, and she has had a term pregnancy. And now after 3 years, she's coming back seeking a second pregnancy.
Okay, so this slide shows what is the decrease in the fibroid size with your Ulipristal acetate. Say after the first course, maybe to 40% reduction, and it goes up to 60 to 65%. I don't know, but though the study says practically, do we see such drastic reduction in the size of the fibroid? It's really questionable. Okay, but definitely the quality of life, the improvement of menorrhagia, everything is better with few courses of Ulipristol acetate. So this was by the European Commission decision earlier. They stopped using, Ulipristol was into the way, and again DCGI stopped this Ulipristol by 2018. Once they gave approval, in 2018, they gave the approval for the use of Ulipristol acetate in fibroid. But later soon, by 2000, I think in 20, they had...
2020 it was withdrawn.
20 they have withdrawn because of the liver safety issues, I think about which we have discussed. And Dr. Asha had rightly pointed out some 6 out of some lakh patients, they tend to have this liver dysfunction, and hepatic transplantation has been done in few of the patients. So that was withdrawn. But then, now Now, how to revamp that? Reuse of this Ulipristal, how we should do. So first thing is, you should, underlying liver disorders patient, you should not do it. And liver function test has to be done with good amount of counseling. Then the next question is how often you are going to repeat the liver function test.
Yes.
Yeah, and
Yes.
first of all, I think we should convince ourselves that surgery also has morbidity and mortality. You know, you can have post-operative additions, post-operative, recently we had a case of surgery went off very well, but then third day she started having nausea, vomiting, and there was a bowel, which was just stuck lightly to that area of surgery. And after 2 more days, we had to go and release that addition. Girl has done well. So remember that every surgery carries morbidity and maybe remote chance of mortality. And morbidity could be additions are much higher than this 1 in 1 lakh liver problems. But when it happens to that particular patient, it is 100% fatal. So kindly counsel everybody that there can be liver problem. And now we are recommending the LFT every 2 weeks.
Yeah.
That is
Rather
what
than-
there is.
Every 2 weeks.
Yeah, earlier it was said at the start
weeks.
of the treatment, you do an LFT, then after completing
No.
4 weeks, you repeat it. But now the DCGI guidelines are very clear that it should be done. So this was the LFT monitoring should
Yes.
be done prior to starting monthly. But now again, this was in the ESMAIA trial. But now we know the current DCGI, they have given approval in 13th December 2021 with the following guidelines. I'll put it. The restricted indications for 5 milligram. We are supposed to use only 5 milligram, not beyond that.
Yeah, and it's impressive that November 2020 it was withdrawn, and by December 2021 we have obtained the permission again.
Yes, yes. So the pharma company has worked so much. They want to bring back the Ulipristal, which has got definite role in management of fibroids. So this is definitely, what are the, Archana, what do you think, what are the indications for using Ulipristal acetate in the current scenario?
I think the indications are in women who are symptomatic, as we have already said, that those who have menorrhagia, and number 2, they're like, as we have discussed already, when there is infertility, is like, not this patient is not in a rush for having the baby. So that's the one. And the second thing is, if patient has condition which where you would not like to operate yourself, like she has comorbidities along with the fibroid, and there in the cases you would say, well, let's do the medical management and not go for surgical thing, and where it really has a great role.
So I think we'll have to respect the guidelines of the DCGI, and according to them, it is to be used only in a premenopausal woman who is not fit for surgery, in that. But of course, with the caveat that she has to have a fit liver also.
The way we have in India today, a lot of diabetics, obese people.
Diabetes,
non-alcoholic fatty liver is very common nowadays.
Yeah. So is it safe to use it in them?
Yeah. So they will have to be careful, and we cannot sort of use it in all the patients, especially now. But again, Dr. Ramani, I think with the gradual use of the drug, as we get more used to it, we'll have more confidence in the usage, and probably the indications might improve. But as of now, we'll have to be very careful, because we are gradually going to return it back to, usage. So we'll have to be very careful in which patients we are going to use it. I think
that's why it is very important to have this kind of discussions where we can share our experiences, and even the, like the companies who have run the extensive research can bring their inputs, and they can enlighten us. Correct. And we can enlighten the delegates regarding its uses. So I think it's very important, and I'm really enjoying this discussion.
I think in the Indian context, Dr. Sonia, if there is a 3 centimeter or 2.5 centimeter submucous fibroid in a perimenopausal woman, it's better to go and take it out by hystoscopy rather than give courses of it.
Of course. So, submucous myomas, always the first line of treatment should be hystoscopic myomectomy, whatever be the age group. Because even in a
perimenopause, when it is not fit for surgery, it's written that when it is not fit for surgery.
Sometimes the patient themselves will say, Doctor Sahab, hame operation nahi chahiye, hame dawai do. But you should convince her that perhaps simple surgery is better than long-term medication.
Yes.
Yeah, recently I would like to share my experience. One patient with severe pulmonary stenosis, not taking a proper treatment, she came with severe menorrhagia, and I found out a small fibroid submucous myoma that was jetting out. So the cardiology clearance was not obtained, but then I thought because it was only a jetting myoma, I can just go and clip it off.
Clip it out.
But when I did it, then I just wanted, because the os was open, I put in a scope and find out, to my surprise, I found out another 2 centimeters the submucous myoma sitting inside. Somehow I was bold enough, my anesthetist was bold enough to manage the patient, and I was able to go ahead with the histoscopic myomectomy, and that was a single time procedure for her. Now let us look into some of the guidelines. This was a guideline by RCOG in 2016 for heavy menstrual bleeding, where they say that heavy menstrual bleeding due to fibroids of 3 centimeters or more in diameter when the hemoglobin is low, you can go ahead with Ulipristal Acetate 5 milligram for up to 4 courses. And again, so this is, and another thing is either we can offer or you can consider women with heavy menstrual bleeding and fibroids of 3 centimeter or more and a hemoglobin level of more than 102 grams per liter. So they are offering it that they can either offer or they can consider. So then what about the NICE guidelines that was released in 2018 that also is in favor of Ulipristal acetate, but we have to be very careful with the serious liver injury associated with that. So we have to monitor the patient. So that if there is no underlying liver injury or surgery or uterine artery embolization is unsuitable, then Ulipristal will be the drug of choice for perimenopausal women with HMG. Fibroids are 3 centimeter or more, particularly when the hemoglobin level is low. I think in the absence of liver dysfunction, the disorder, this patient can be offered. Then there was again another guideline by the Italian Society where they were also in favor of treatment of symptomatic uterine fibroids with COCs, LNG-IUS, but they are now moving on slowly to the Ulipristal acetate. So now
what is the cost of Ulipristal acetate, by the
way?
Yeah,
that I am coming to the rare end.
130 rupees per tablet.
Yeah. How does it have any impact on the future pregnancy rate, abortion rate, or take-home baby rate?
Nothing.
No, nothing. No. I don't think it has any role because madam.
Yeah. So there are again lot of literature evidences to show that there are good pregnancy outcomes. This was an article published in 2018. 7 studies included 6 case reports, 1 retrospective series, and 24 post of UPA pregnancies, where they found out that it can permit consumption and a favorable pregnancy outcome. Again, there was a single case presentation of Ulipristal acetate prior to ART in fibroids, and the outcome is it has got a triple effect. It ensures prompt symptom relief, reduces the size of the myoma, and it improves the morphology of the uterus, thereby improving the IVF outcome. So again, this was another study from Spain where successful pregnancies has been reported after Ulipristal acetate. One more from, I think, I don't know from which country, again, after an ICSI procedure, successful outcome. Again, there are few more case reports. So I would request the learned panelists to share if you have come across a single case of ART, pre-ART, where you have used Ulipristal acetate and the outcome of the pregnancy.
Yes, again, in a very, not in a large myoma. I started to use it when this was, when it was allowed. That was early, not now, earlier. Now when it is
2018 to 2020, probably.
Somewhere in 2019, I used it. And then the idea was to reduce, just as Archana was saying, the myoma was more than abutting the endometrium, more than that. And it was on the posterior wall. It was an intramural, but more than, 50%. So in order to reduce the size, we used it. It was only given for 3 months. I did not use it for more than that. There was I don't remember how much was the reduction in size, but then we did an ART. I was careful to put the embryo not at the site of the myoma, a little lower than that, and trying to avoid that site where it was. And then we were successful in getting a pregnancy in that patient. So I do remember using it slightly, but not to a large extent.
Archana, yeah, because in the world literature also, we do get only case reports.
Yes.
Not series, big series has not been reported. Yeah. What about Asha madam? Have you come across post ART? I mean, with the prior use of EP?
No, because I think 2 of my patients conceived spontaneously.
Yeah.
We did not have to go for ART.
No,
Archana?
I have not come across, because this has come recently into this thing, again. So maybe in future we are looking into such kind of scenarios where they had a prior treatment and then IVF and then results. So I think this is still, it will take some time for us to collect the data on this aspect.
Yeah,
now I have this obese girl
my
with
experience of one patient who had 18 myomas and she was operated by Dr. Kurian Joseph. He has done an open myomectomy because it was 24-week size. And after 1 year, she came to me because she was a resident of my city with again multiple intramural myomas. Small myomas, and the uterus was around 8 to 10 centimeters, 8 to 10 weeks of pregnant uterus. So then she was very keen on conception. I did a hysteroscopy, the cavity was normal. So I gave her UPA for 1 course of UPA.
1 course.
Then, prior to that, I had picked up the embryo, and then embryo freezing was, oocytes embryo freezing was done, gave UPA, then I transferred. She became pregnant. But on doing an LSES, I found that was another big myoma sitting in the uterine cavity. So this time, along with the baby, I removed that uterine myoma also. And of course, I couldn't remove the uterus. Exteriorization of the uterus was not possible because the entire uterus was plastered because of the previous myomectomy. I had to go through an extraperitoneal C-section. So then I told that girl, come and have a LNGIUs at least for your symptoms to become better and for contraception. She never turned out, but instead she turned out after a year's time with another spontaneous
pregnancy.
Spontaneous conception. This time she had another large myoma that was sitting in the lower uterine segment. Then I had to remove the myomectomy, go ahead with the myomectomy, then remove the baby. So that was the story of my only one patient who had conceived with UPA, and now 2 more of my patients are on UPA. After this release of this ban, I have put them on Ulipristal and they are waiting for ART. Now, last question is...
My patient was also on some homeopathic medicine along with the UPA. So I don't know
whether it is homeopathy or allopathy.
It was UPA, but that is what limited experience.
Okay. Cost of the therapy, Dr. Asha Vada was asking. I think it is
130. One of the brands is 130 rupees a tablet.
It is 11,000 for 1 course of treatment. 11,000 precisely.
140 to 50 rupees per tablet.
Yeah, multiplied by 90 days. So that's how you calculate. So it is good to inform the patient in advance.
I think it's equal to the cost of 1 GnRH analog of 11.25.
Yes,
it is equivalent, but yes, patient should know the total cost of the treatment rather than just the tablet for 1 month or so. So that the whole course would cost that much. And we can ask Jacksonpal to reduce so that, we can really offer it to many women.
I'm sure they will. I'm sure they will.
So to summarize, UPA is a new, effective, well-tolerated option for preoperative treatment of moderate and severe symptoms of fibroids, intermittent treatment of moderate to severe symptoms of uterine fibroids in adult women of reproductive age, correction of anemia. It is fast-acting, then had better tolerability profile when compared to Leuprolide. It results in significant reduction in the size of fibroids, which last at least for 6 months at the end of the treatment, and keeps the estradiol levels and follicle phase range. Thereby, there is no incidence of heart flashes, and there is no impact on the bone marrow turnover, allows for planning treatment strategy tailored to meet an individualized patient needs. UPA may be a good option for women with fibroid uterus who wish to avoid surgery, and there is or when they want to postpone the surgery. So perimenopausal women who are not willing to undergo surgery despite the failure of other medical treatment.
Good evening to all respected doctors. I am Vijay Singh, the brand manager of Yuliprist. Bring greetings from Nari division of Jackson Park. We thank you for this opportunity to connect with you all today through this webinar, and are proud to present Yuliprist 5 mg tablet for long-term management of fibroids. Doctor choose Yuliprist to save her uterus, as we at Jackson Park are fully compliant with the latest guidelines and recommendations given by CDSCO and the DCGI about the liver safety, and suggest the monitoring of LFT during treatment. And doctors, yes, choose Yuliprist for the management of uterine fibroids when the surgical procedure and embolization not appropriate, not work, and the patient not willing for the surgery. So doctors, please prescribe Yuliprist, as the doses already we have discussed in detail. And I personally thank you to all the participants for attending. And yes, the Yuliprist is safe in long-term intermittent therapy up to 8 treatment courses. So thank you very much, doctors, for attending and participating.